Hi, Muhammad Al-Mala here. Welcome to case 3 of our small pupil cataract surgery series. I found this case also from 2016, and as you can see here, the pupil is quite small. It looks like there are some posterior synechii here where the iris is attached and scarred down to the underlying lens or the anterior lens capsule. We are putting viscoelastic into the anterior chamber, dispersive viscoelastic here, and we see that with viscodilation, viscomydriasis, we get maybe a 3 millimeter pupil. So my first step here is going to be to lyse these adhesions. I'll probably use a cyclodialysis spatula to separate the iris from the lens. And then we'll assess the pupil, see how much dilation we get, and then go from there. We'll make a plan as to whether to use a pupillary expansion device or to proceed without it. This is a cyclodialysis spatula right here, and you can see it's fairly straightforward to lyse these adhesions. But you can see the posterior synechia here really are quite extensive. They're not just at the pupillary margin, but they go a little bit further back as well. So we'll do as much as we can here through the main incision, but we may have to go through the side port incision to release some of these adhesions here that are sub-incisional. We'll see. So no, it looks like we were able to do that through the main incision. But if you're not able to, you can always go in through the paracentesis, and of course you can always make another paracentesis to allow you for better access. So we're going in here with viscoelastic, see how much dilation we get. We have a nice, the pupil is more round now, but still only about 3 millimeters in size. So probably this is not going to be a case where we can just do viscomydriasis. We're probably going to end up needing to do some sort of pupillary expansion device, and my go-to, of course, is the Malyugin ring. I'm putting together a case series on small pupil cataract surgery. I'll attach a link to the playlist in this video. I'll see if I can put it in the comments as well. And we're going to put together a series of small pupil cataract surgeries. So here I'm using a Malyugin ring. I use 0.12 forceps to open the main incision and hold it open. And then it's really nice here if you're able to, as you inject, to engage as many of the coils as possible. Not always possible, but sometimes we're able to engage some of them. Here we have engaged 2 of the coils on the pupillary margin, and now we are removing the inserter. This is a full unedited case, and we're seeing this in real time. So sometimes putting in a second instrument can help release the Malyugin ring from the inserter. So we will place each of these coils one at a time, and the Malyugin ring provides 8 points of fixation for each of the coils and for midway between each of the coils as well, and does give you a nice round pupil. I have a whole other video on how to place a Malyugin ring, and I'll try to link it to that as well. So one way here when you're first placing the coils is to place viscoelastic between the iris and the lens, and that can create that potential space for the coils to go into. So we've placed here the third coil, and we're having a hard time getting that luster out of there. MST has a nice instrument to help place these Malyugin rings, and it could be a nice second instrument. I'm not using it here. So more dispersive viscoelastic. Want to make sure the corneal endothelium is nice and coated as we're doing this. And we're just checking that coil there, and then we'll place the third coil now. Okay. The fourth coil rather. So now the final coil is placed. We see a nice big round pupil here, and we can proceed with surgery. We see where the iris, the posterior synechia is still attached to the anterior capsular surface there. We put in more more dispersive viscoelastic. We want to make sure we have a nice stable anterior chamber, and then we'll go in with the cystotome followed by the capsulorhexis forceps. Point 1, 2, very important. Stabilize the globe. Make sure things are nice and stable for you and secure, and you can take your time and feel confident doing the procedure without having to worry about the patient moving. So we've initiated the capsule rhexis here. We'll make a few more passes there to raise the flap, and then we're going to go in with capsule rhexis forceps and make a continuous curvilinear capsule rhexis. Okay, very good. We're getting some good centration here. Things are proceeding nicely. So having a Malyugin ring doesn't make you immune from having iris prolapse. So we've still got to be careful about avoiding iris prolapse as we do the hydro dissection. So we'll go in, we raise the capsule, a little bit of air bubble there, and we raise the capsule and we hydro dissect. Thankfully, no iris prolapse here. At this stage in my career, I was doing some hydrodelineation, and it looks like I'm doing that here. And this is with the Bosch & Lomb Stellaris machine, which is a Venturi system. I am doing still horizontal chop. With this machine, I would go in and create a central core here, carve out a central core, and then I'd go in with an Aguilar chopper and do a horizontal chop maneuver. So we bury the tip into the nucleus here to get good counter traction. And that looks actually like a pretty good crack. The resolution in this video is really quite low, but I can tell we've got a good crack there. Decent rotation. Looks like I'm going to do a second crack here and try and get at least 1/4 out. So we've got one heminucleus has been split into quarters. We've got our first piece out here. You can see with the Venturi system how that piece really just comes up quite readily. Decent rotation. And now we've got the second heminucleus. We'll crack again, a horizontal chop. And we'll remove that piece here. Venturi system quite efficient in emulsifying those pieces. Okay, I'm going to crack some more, do some more horizontal chops. And surgery is proceeding well. We're making progress here. And we're probably going to have an epinuclear shell because of the hydrodelineation. So the epinuclear shell is really nice when you're learning phaco chop. It gives you a little bit of buffer between you and the posterior capsule. I don't do hydrodelineation anymore, but I think when you're learning phaco chop, it is nice to have that. Then, of course, you got to deal with removing the epinuclear shell at the end of the case. So here we have the epinuclear shell, and with the Venturi system, it's really quite easy. You've got high vacuum here. I have my second instrument protecting the posterior capsule. But yes, here we remove the epinuclear shell. There is still some cortical material, and we're going to get that, looks like, with IA. So I'm happy with that. We've gotten the nucleus out. While I'm waiting for my scrub tech to get the IA, I will go ahead and inject some BSS through the side port just to remove any lens material that may be there. And then I'm going in here with IA, and we are removing the rest of the cortical material that's there. Some subincisional cortex still remaining. And then we're going to polish the posterior capsule here, most likely with the terry squeegee, and then put in viscoelastic. Oh, it looks like I'm not polishing the posterior capsule. We're just going to fill the capsule bag with with viscoelastic. We're using a cohesive viscoelastic. We'll insert the intraocular lens, and I'm using a Softech hydrophilic acrylic lens here. I don't use this lens anymore, but at the time this is the lens that I used, and it actually worked out really quite well for many of my patients. And then before we go in with IA here, we got to remove the Malyugin ring. Very important. If you go in and remove the viscoelastic like you're in autopilot, you're going to have to go back in and put viscoelastic in to remove the Malyugin ring. So I like to remove the subincisional scroll first, and got to make sure that scroll stays above the iris. If it goes behind the iris, it's not a big deal. You just got to spend a little more time getting it out and possibly using a second instrument. So two of the scrolls are off, and I remove that third scroll off the iris, and I'm curious to see how I'm going to get this out of the anterior chamber. It looks like I may be just using Westcott scissors to cut it, which is my preferred method, but of course you can reload it onto the inserter as well and just pull it back in. Sometimes if you reload it onto the inserter, it can torque in ways that you don't predict, but I like to just go ahead and cut it with Westcott scissors. I don't reuse these, they're not reusable, and then I pull it out of the anterior chamber with 0.12 forceps. So the Malyugin ring is fairly atraumatic in this case, and we're going to go ahead and now with IA and remove the viscoelastic. We'll go behind the lens. We'll remove all the viscoelastic from the anterior chamber. We'll hydrate the wounds, and that will be it for the case. So, small pupil cataract surgery, case number 3 of the series. Make sure to check out all the cases. I'll link to the playlist. If you have any questions or comments or things you think I could, that we should do differently, or you want to share your technique, please feel free to comment. Thanks for checking it out. I'll see you in the next one.